the interaction of menin with the KMT2A has been found to be very important in the pathogenesis of nucleophosmin or NPM1 mutated AML, also AMLs and ALLs with the rearrangement of the KMT2A gene. Ziftomenib, as it's now known, is an oral potent inhibitor of menin, and in vitro has shown activity in cell lines having NPM1 and KMT2A mutations. In the phase 1A portion of the clinical trial, we evaluated doses up to 1,000 milligrams daily, and we actually saw 2 responses in patients with NPM1 mutation, and also, and kind of off-target, as far as we know, response in a patient with a SETD2 and RUNX1 mutation. But in that phase 1A portion of the study, we were able to identify 2 dose levels at which we saw responses and manageable toxicity. And that was 200 milligrams and 600 milligrams once daily. And so we brought forward those 2 doses into a dose optimization portion of the trial, a phase 1B. And that's mostly what I'm reporting on here at ASH 2022. The important take-home message from that study is that in NPM1 mutated patients, we found a dose of 600 milligrams once daily to be the optimal dose, based on the fact that in the NPM1 population, we had 20 patients. We saw a response rate of 30%. Those are CRs, true complete remissions. That dose level was also associated with a pharmacokinetic and pharmacodynamic profile that suggested it would be superior to the 200 milligram dosing. And so this 600 milligram dose has now been identified as the recommended phase 2 dose agreed upon by the U.S. Food and Drug Administration that we're bringing forward into an expansion in NPM1 mutated patients. Now, what's interesting about our findings is that we saw different results in the KMT2A rearranged patients. There's clear biologic activity. We've seen clearance of the marrow of blasts very rapidly. However, we also saw a signal for an atypical presentation of differentiation syndrome. I mean, there was leukocytosis, but also often with increasing blasts in the peripheral blood. But with continued therapy, those would go down. But we also saw flares of the disease in different extramedullary tissues. For example, one of my patients had flare of the disease in the gingiva, and then in a knee, synovitis, and in muscle, sinus, pleura. And that led to, with that initial rise in the white count, led to some investigators taking their patients off study early. We believe that this early signal of differentiation and leukocytosis may be overcome by combining the ziftomenib with chemotherapy in the KMT2A rearranged patients. And that's what we plan to do in that population. But in the NPM1 mutated population, we are going forward with 600 milligrams daily. And of course, we have combination studies planned for the next trial.